Our last speaker is Dr. Sam Hahn. He's an assistant professor of medicine at The Ohio State University. He's an expert in chronic pancreatitis and pancreatic endotherapy. He's an excellent clinician and researcher. He's one of the best fellows we've had here. We miss him. We're very happy to have him back. Welcome, Sam.
All right. Thank you so much, Anna, for that kind of introduction. And thank you, Dr. Wog and Dr. Deloy, for inviting me here. It's really awesome to be back at Colorado. Definitely miss it. So I was tasked with talking about ergonomics, fluoroscopy, and radiation safety. And I don't know if you can tell who the endoscopist in this picture is, but it's actually Mihir. He was serving as a model to illustrate the ergonomic challenges of performing third space endoscopy. And we'll touch on this later, but there's a lot of unnatural postures involved. I have no conflicts of interest to report. So really today, we're gonna focus on providing an overview of the importance of ergonomics as it relates to endoscopy. And then we'll also go over the basics of fluoroscopy use and also provide some practical tips in terms of how to reduce radiation exposure. So to really kind of generally describe ergonomics, it's the study of people's efficiency in their working environment. But more simply stated, it's the science of designing a job to fit the individual instead of forcing an individual to fit a job. And as it relates to endoscopy, I think the field has done a really poor job at this, as we're really kind of forcing endoscopists to fit the job and not really tailoring the endoscopy position or the art of performing endoscopy to fit the individual endoscopist. So we're going to touch on 4 pillars within ergonomics that I think we can actually do something about. And so we'll focus on these 4 things. But to start off, why do we care about ergonomics? And the reality is that as endoscopists, all of us are at high risk for developing musculoskeletal injuries related to performing endoscopy. There was a survey study sent out to ASG members, and among the 684 endoscopists who responded, more than half of them responded musculoskeletal injuries related to performing endoscopy. And they found that risk factors for developing injury included a higher procedure volume defined as performing greater than 20 cases a week, greater time spent performing endoscopy defined as scoping for greater than 20 hours a week, and then a greater number of years spent performing endoscopy. So I think that actually includes all of us in this room in terms of people who have multiple risk factors for developing musculoskeletal injuries. And another big kind of caveat to all of this is that musculoskeletal injuries, obviously it leads to pain and discomfort, but it can lead to decreased productivity, lost days at work, increasing levels of burnout, decreased job satisfaction, well-being, and also the theoretical risk of long-term disability and decreased quality of life. So in terms of interventional endoscopy, therapeutic endoscopy, advanced endoscopy, however you want to state it, there are definitely certain risks that's just a part of the nature of doing this job. So as you can think of, for example, just putting a stent, let's say a 10 French stent past the biliary stricture. So you're exerting such high forces in terms of both your left hand and your right hand. So in terms of your left hand, think of your thumb, how much force you're using to push down on the big wheel and the elevator in select situations. And then with your right hand, think of the kind of the first 3 fingers that you're using to feed the stent. I mean, we're not even talking about alternating RCP, which is its own set of challenges, but just think of all those high sustained pinch forces. And over time, that just results in microtrauma. And this leads to tissue inflammation, tissue remodeling. So that's how you can really develop these overuse repetitive injuries. And so there's a study done back in the early 2000s of ERCPists, as Raj Shah would say, but basically biliary endoscopists. And they basically reported that 2/3 of them had symptoms that started after starting ERCP. And interestingly, in the study, they actually had occupational therapists analyze the ERCP rooms. And basically, 2/3 of the rooms were labeled as poor working environments for performing ERCP. And not much has really changed in terms of the ERCP room. If you really think about it, we have maybe more space, but we have more equipment than ever, more monitors. So nothing has really fundamentally changed in terms of advanced endoscopy in the room situation that we have. And then third space endoscopy is really its own unique ergonomic challenge. If you think about performing third space endoscopy, you are constantly in prolonged awkward postures You're constantly torquing in unnatural ways. And a lot of times you're really looking at the screen in a way that your body is not actually parallel to the screen, but you still have to keep your eyes on the screen the whole time. And that's where I want to bring this picture back. And when Dr. Wag is performing a poem, for example, you can see that he not only has to torque his left hand and his right hand in unnatural ways, but he also has to deal with so many different foot pedals. There's like basically 4 different foot pedals that he has to keep track of. And this leads to imbalance in terms of your posture. And also, it's hard to keep track of all those foot pedals. So third space endoscopy, I know, especially among you guys as advanced endoscopy fellows, I'm sure half of you probably said in your application, I'm interested in doing third space endoscopy. I want to do POEM. I want to do ESD. But I really want to present to you the unique challenges and kind of risks that are unique to third space endoscopists. Especially in the US, where most third space endoscopists are actually also pancreaticobiliary endoscopists, which is kind of a different model from Asia, where you kind of have resection specialists who also don't do PB endoscopy. So these are just some general tips for your endoscopy unit. Starting with the monitors, so you want to place them at eye level between 52 and 182 centimeters away from the eyes, depending on the size of the monitor. You want your bed height to be approximately 10 centimeters below your elbow height. You want to be standing on cushion mats that are slip resistant and waterproof. And as shown in our other picture, we definitely want foot pedals that are easily accessible to you. This is kind of a schematic of an ergonomically friendly endoscopy room. I want you to take note of the athletic stance taken by the endoscopist. So really what that means is that your knees are slightly bent, your knees are shoulder width apart, your elbows at an appropriate height, the monitors and the beds are also at an appropriate height for you. So I think we've done a really poor job in terms of making endoscopy equitable and inclusive for all types of endoscopists. And with that being said, I think the most important things are your monitor height and your bed heights. And this is a must for every endoscopy unit. So you need to have adjustable monitors. So they really have to be able to count for the 5th percentile of female height to the 95th percentile of male height. Same thing with the beds. They have to count for the 5th percentile of female height all the way to 95th percentile of male height. And I think the real challenge here actually happens with fluoroscopy units. So when you have built-in fluoroscopy units where you find at most academic medical centers, the fluoroscopy bed does not actually go down very low. So a lot of times the shorter endoscopists have to use a stool to perform an ERCP, which is obviously not, not appealing to anyone or safe for anyone. And I also want to list or cite a specific survey study that was published in the Red Journal last year. And it was basically relating to female endoscopists, including fellows and attendings, as to why they didn't pursue a career in advanced endoscopy. So the 3 biggest factors were family planning, and then as it relates to this talk, the risk of pregnancy with radiation was a big one. And then when you think about it, right, there's no ergonomic equipment that's available, that's specific for females in general. So we talk about the importance of lead aprons, but how many endoscopy units have you worked at where they have pregnancy-specific lead aprons, right? And these are just, for an example, these are aprons that have adjustable waist basically, and also added shoulder padding to really help the female endoscopist as they're pregnant to be able to adjust their lead apron as they progress. And then a big part of, I think, ergonomics is going to be endoscopy scheduling. And this is hopefully something that you have some control over. But really, I think a general tip is to space out your endoscopy sessions throughout the week. If possible, try to have a day of not scoping in between your days of scoping. Also try to implement half days if you can. That at least will lighten the load for that particular day. And then you want to be able to take adequate breaks between cases. I know the economics of endoscopy kind of prohibits you from taking long breaks, but there are definitely long cases after which you need to take a break. I actually think Mihir Wag is a great example of someone who takes really good breaks. He is so conscientious after performing a poem of really taking like a 15-20 minute break where he goes off by himself and he cannot be found. And he's recharging, and you need to do that. We also know from the surgical literature that micro breaks can also be super helpful during cases. So in the surgical study during laparoscopies, basically they randomized surgeons to getting a 1 to 2 minute micro break during the procedure. And what they found was that even though the procedure time was not at all different, The surgeons who performed microbreaks actually had much lower rates of post-procedure pain. They reported that they had higher levels of focus, mental and physical. So something just to think about, particularly during your challenge cases. You don't have to be scoping the full 2 hours. You can certainly take a break. And then in terms of an ergonomic timeout, I think this is something that's very easy to implement into your procedural timeout. So when you're starting the case, just make sure that everything that you have control over is in an appropriate position for you and it's comfortable for you to use. So as with everything, education is so important. And the reality is in our fellowship training, we have a very low rate of ergonomic training. There's a survey study that was published in 2019 where basically among all GI fellows, 28% reported that they received formalized ergonomics training during their fellowship. At the same time, program directors reported, 68% of program directors reported that they provide formalized ergonomic training. So that's a whole different issue, but there's obviously a discrepancy, but it really highlights the need that we need to formalize training within our GI fellowships. And probably most importantly, this starts with the faculty, the trainer. You guys are all the trainers now. And so when you're training people and training fellows specifically, they're watching you. They're watching how you scope. They're watching how you position the patient. They're watching how you use different equipment. They're watching how you communicate with the team. So I think ergonomic training is not just for fellows, but it's really applicable to all levels of endoscopists. And then actually, so Mihir Wag was the chair of the ASG training committee. And last year, they really produced an excellent document that details a curriculum for ergonomics training for GI trainees. And they listed kind of 3 types of skills, but the first of which was cognitive skills. And so really how this relates is understanding ergonomic principles and really recognizing when your muscles are strained and knowing when to take a break. Obviously identifying devices and room accessories that can decrease strain during endoscopy. And then understanding the use of different protective devices, whether that be lead aprons or whether that be eyewear. In terms of technical skills, this really relates to comfortable body position for you while you're performing endoscopy. Obviously, we talked about adopting an athletic stance before, but in terms of the right hand, for example, making sure that instead of doing a first-year fellow tactic, which is fisting the colonoscope, actually holding it like a violin bow. And actually, Dr. Hamad does a great example of this, where he really holds it very lightly like a violin bow. And then he uses kind of like a finger rolling technique, or some people describe it as a cigar rolling technique. I don't know how many people roll their own cigars, but it's a rolling technique with your fingers instead of using your wrists to create a lot of torque strength. And then in terms of non-technical skills, I think the biggest part is communication. Great endoscopists are also really good communicators. So being able to communicate with your team members about ergonomic principles to avoid injuries, obviously including an ergonomic timeout, and then making sure that the patients are appropriately positioned, knowing how to effectively schedule your patients. So a good example of this, for example, that Dr. Wag does is he doesn't want to do more than 1 poem a day when he's doing an endoscopy. I think that's the economics of endoscopy always wins. And then in terms of, for example, there's no specific evidence to support stretching before endoscopies, but we do know that stretching relaxes muscles and can help prevent injuries. So stretching before endoscopies can always be helpful. But I think the general point is kind of adopting this mindset that endoscopy is like a sport, and that as an endoscopist, you are an endo athlete. And so you need to take care of yourself, not only during the procedure, but before and after the procedure as well. And then the big elephant in the room is really endoscope design. The reality is that endoscopes were never really designed for comfortable human usage. And we have forced the endoscopist to adopt the endoscope basically. So we really do need disruptive innovation. We're seeing it in surgery in terms of like the robotic cases. And who knows when that will happen in endoscopy, but basically we do need a disruptive innovation to change the way that we can scope so that it doesn't create strain on us physically, because there's already so much mental strain as it is. Next, we're going to move on to fluoroscopy and radiation. And so just as a quick reminder, radiation is just a type of energy, and fluoroscopy is an ionizing radiation that penetrates through tissue and can be captured by the detector device. And this is kind of a classic schematic of what we're all going to have in our endoscopy units, but it starts with the X-ray tube below that produces an X-ray beam that goes up The collimator is located at the exit port of the X-ray tube, and that basically adjusts the amount of energy or amount of X-ray beam that can be passed on through. And so the endoscopists themselves can actually adjust the blades of the collimator to basically narrow or widen their field of view or region of interest, if you will. And then most of us now have these image intensifiers or image displays, but basically they're digital now. So they capture the X-ray beams and they produce a digital image. And the nice thing about these things is that you can have a magnified image without actually increasing the amount of radiation used. So most endoscopy units will now have either a fixed unit or sometimes still a portable C-arm. Usually you see a portable C-arm most in the OR. And then they can be controlled with either a fluoroscopy technician or the endoscopist. I think my general preference and many endoscopists' preference is to be able to control their own fluoroscopy. And fluoroscopy can be performed with either continuous X-ray generation or pulsed X-rays, starting at a frame rate of about 30 frames per second to less than 1 frame per second. And then loop recording is a feature that's available in most units that basically allows you to store and review short video clips of fluoroscopy. In terms of managing radiation dose, I really want to reference a paper that Anna Deloy helped write for the ASG Quality Assurance and Endoscopy Committee. They produced a fantastic document about basically fluoroscopy and radiation safety last year. And the general principle is ALARA, or as low as reasonably achievable in terms of your radiation dose. So there are kind of 5 factors involved. The first of which we're going to talk about is radiation time, which is by far the most important aspect of radiation exposure. So how can we use less radiation? So one general tip is to use post fluoroscopy with a low frame rate, and then to use the last image hold function. Rod Shaw is a huge fan of this, but basically you can store the last image that is available on your monitor, and you can not only review it, but you can actually archive it. So instead of taking an additional picture, you can just use your last image hold for this. And then in terms of the distance from radiation source, the inverse square law dictates that exposure is inversely proportional to the square of the distance from the source. So you want to be as far back from the source of radiation, which is actually typically scattered from the patient for you. So you want to be as far back as possible, obviously realizing that you have to be close enough to insert the endoscope. Shielding is a huge thing that is mandatory in all of our fluoroscopy units. So for endoscopists and endoscopy personnel, this really involves the use of lead aprons that are at least 0.5 millimeters thick. You want to have usually a 2-piece because that's a little bit more comfortable and it distributes the burden of the weight. And then you also want to have a thyroid shield and leaded eyewear. I was fortunate enough that my advanced endoscopy fellowship attendings bought me personalized equipment for this. However, for fellows who are looking for jobs, I would highly recommend that you make sure that your new job includes all 3 of these and have that leveraged into your contract. Of course, it's nice to have personalized equipment as well. And then in terms of the room itself, so there was a randomized study that found that if you put drapes on this radiation source, basically you can decrease up to 90% of the scatter radiation. And then there are different types of shielding available in rooms. So there's ceiling mounted, there's table mounted shielding, there's also portable shields, and we're going to see examples of these. So this is something that hangs from the ceiling. This is in room 16 here that Dr. Amendowicz primarily uses. And then this is affectionately known as the wall, but it is a portable shield that primarily is used in room 14, but all of them are really effective in reducing the amount of scatter radiation that you receive. And then again, to talk about education, education is so important, but formal training and proper fluoroscopy use is really limited during your endoscopy training. So there's a survey study that found that even though 62% of advanced endoscopists control their own fluoroscopy, less than half of them actually received any training on how to operate their own fluoroscopy systems. And a Stanford study found that even a 20-minute video on best practices of fluoroscopy use can lead to lower radiation doses. Again, symbolizing how important it is just to receive basic education. And then even putting a red light on that turns on basically whenever you're using fluoroscopy was found to reduce radiation use. And so this all really points to the need for fluoroscopy cognizance. And I can't speak about this enough for junior attendings. It is so hard during challenging cases to keep your foot off of the pedal. You want to, it's just kind of like by nature, you want to keep your foot on the pedal and you want to see everything that's happening. But the reality is you just need to develop that cognizance of knowing when do I need fluoroscopy, How much fluoroscopy do I need? Can I get away with just a pulse rate fluoroscopy with a low frame rate? So all these factors need to kind of just be developed, and it starts during your own training. In terms of current technologies, artificial intelligence can certainly help. There's currently a system called Fluoroshield that's offered by Omega, and it basically is a second collimator in your X-ray machine, and that basically automatically adjusts the collimators so that the amount of energy going into the field outside of your region of interest is blocked. And so it uses a convolutional neural network artificial intelligence system. So what that does is it basically automatically detects where it thinks that you're interested in looking at, and it'll reduce the amount of radiation that goes to the outside areas. And I'll show you an example of this in the next slide. And then whenever possible, using non-fluoroscopy techniques. A lot of us do this already, but for example, doing EUS before a potential stone case to make sure they have a stone, just so that you don't do like a ERCP that requires radiation. And then using cholangiopancreatoscopy whenever possible as well to directly visualize structures instead of using fluoroscopy as well. So this is a video of Fluoroshield. So I just want to highlight to you how it works. So you can notice that this region of interest box constantly adjusts, and it's basically trying to guess where you are looking at. So this is a patient with actually biliary candidiasis, but you can see it detects the spyglass really well, detects wires fairly simply. And again, it really does reduce the amount of radiation you're using. This is placing a stent past a stricture, and it also like kind of pulses it automatically, so it reduces your radiation that way. This is a single balloon ERCP I was doing. Again, it's also able to focus on where you're interested in. This, it's one drawback I think is like pancreatic ERCP. You can see that the pancreatogram is happening over here, but the focus of interest stays here. So obviously there's some kinks to work out. So it's not perfect, but definitely something if you guys have an Omega system, it usually comes standard with it now. So it takes a little while to get used to it, but once you get used to it, it will significantly reduce your radiation dose. And then this is an example of using cholangioscopy. So this was a patient I actually did last week, 18 years old, in her second trimester, came in with gallstone pancreatitis, MRCP showing archicholedocholithiasis, including a obstructing stone at the ampulla. And Raj and I published a technique for removing these kind of stones using not using fluoroscopy a couple years ago. And I'm going to demonstrate that in this case. But basically, we have a bulging ampulla with an impacted stone. So I actually started with a pre-cut. And the patient was very adamant that she wanted me to really not use any fluoroscopy at all. So I said I would do my best. But we're doing a pre-cut. And while we're doing the pre-cut, you can start seeing the stone come out. And eventually the stone is going to pop out. And that really facilitates biliary cannulation because you're able to really get in very easily. And then I aspirated bile, and then I did sphincterotomy. And then I go in with the cholangioscope, and you see there's lots of stones. And we're going to use the SPY basket, which is a cholangioscopy specific retrieval basket that I find very useful in these cases. But basically the technique is you put the basket below the stone and you open it past the stone, and then you basically start withdrawing the basket. And it is actually really amazing how well it works in terms of getting bile duct stones. I think for pancreatic duct stones, it doesn't work as well. But for bile duct stones, it's really effective in grabbing the stone. And then you bring it out. Then you can see it's a fairly big stone. We wash it out, we take it back, and then we go in. And we're just basically going to repeat this process. And this way you can do everything under direct visualization. You can go all the way up to the intrahepatic. In some cases, you can even go into the cystic duct, but you're basically trying to take out as many stones as possible without using any fluoroscopy. And this is a case where, because the basket is actually so wide and so kind of deep, it allows you to even grasp 2 stones. And so here we got 2 stones at once. And so for this patient in a 40-minute procedure, we removed 22 stones, all without using any fluoroscopy. So the patient obviously was very happy about something like this. I just wanted to thank you for your time. I'm obviously fortunate to be at OSU, where I'm with a group of excellent pancreatologists. But I do want to just make special note of my time here in Colorado. It was unbelievable. I certainly wouldn't train it for anything. I wouldn't trade it for anything. And I think a lot of what I have become today, everything I've accomplished, is the direct result of the training I got here. Thank you. Sure.
Okay, we're going to do a quick Q&A. And then, so we'll invite all the speakers from the first and second sessions to come on up. If you guys have any questions, you can raise your hand. We'll load that platform where you can type in. We'll probably take like 10 minutes of questions. And then what we're going to do is you guys will go upstairs, grab lunch, and then come back in. And we're going to do sort of a working lunch till about 12:40. So basically talk about careers after interventional fellowship. So this should be informal. Think about things you guys want to ask. You have so many experts up here from so many different programs. I really encourage you to pick our brains. And then we will head over afterwards to the endoscopy lab, and we'll give you a little more instruction about that. But as you're getting lunch, if you don't know what group you're in for the scoping, you can just stop by the registration desk. They should tell you, but I think it's on the back of your badge or something like that. Okay?
Just to clarify, bring your lunch in so we can, discuss during lunch. All right. So I think we have a question from the audience. All right. So let me read this question. It's for Dr. Wani. It says, could you comment on the use of acetic acid for BE surveillance in addition to virtual chromoendoscopy to detect flat dysplastic lesions? And comment on recent Kyoto consensus on redefined GE junction, Barrett, and Seward type 2 adenocarcinoma.
I can comment on the first question. The use of acetic acid is actually fairly prevalent outside of the United States. A lot of advanced endoscopists or folks who do a lot of work in the field of Barrett's use acetic acid instead of using virtual chromoendoscopy or in combination. I feel like that practice has not caught on here in the US. I personally don't see any added advantage to virtual chromoendoscopy, but that is definitely a technique that you can use in your practice. I just find it a little bit cumbersome because you now have another device that you need to use to spray the agent, the time that it adds compared to just flipping on a switch or hitting a button and you can move to virtual chromoendoscopy. I will have to get back to you on the Kyoto classification. I did see that manuscript come through, but need to review it.
Perfect. Okay, the next three questions are all sort of EMR questions. So some of these are for you, Hazem, but I think all of us perform it so we can all sort of weigh in. The first question is, for large colon polyp EMR, what are your thoughts on soft tip versus APC of the margin versus hybrid APC? Relifting using water jet after EMR and treating both margin and base with APC for reducing recurrence. Yeah, it's all the same question. For large colon polyp EMR, what are your thoughts on soft tip versus APC of margin versus hybrid APC, which they're defining as relifting using water and treating both the margin and base with APC?
I think we have data now for snare tip soft coagulation that are very strong, stronger than what we have. APC, I think, was what we mostly used because that was the only thing that's available. But the data that are there for snare tip soft coagulation is much better. And I think it does give you a deeper ablation as well compared to the superficial nature of the APC that's used. Now the hybrid APC, I think it's a newer technique that's been studied, and we'll see what the data and the results will be. But for the time being, I think snare tip soft coagulation seems to be the way to go. But I don't know what.
And I would just say that you already have the snare and you have everything set up, so it's one less device that you need to spend on. So that's another use.
Yeah, so I switched now from doing APC to snare soft
soft
Yeah, I think
coagulation at the
all,
same time.
all of us have now switched to soft tip. I think the important takeaway is that you see any visible lesion, don't go to APC as your preferred approach to take care of the visible lesion. You need to try and resect that.
Okay, this is another EMR question. To the panelists, for EMR cases, do you prefer endo cut yellow petal versus force coag blue petal for cautery? Awesome.
There is a study done by Dr. Rex recently showing no difference, and I don't know how that is possible. It is possible, but all right, it's just like it all depends on how large the lesion is. For a smaller lesion, less than 2 centimeter, I don't think anything will make difference. But if you're doing EMR and there's multiple pieces and you're using too much coagulation, you have higher risk of what we call post electrocautery coagulation syndrome. And I think it is much higher with coagulation versus endocut. However, it's so hard to prove that because you will need a sample size of maybe 1,000 patients. But that's my personal opinion. So I would like to see what you guys think about it too.
I use Endocut. I think this applies more to the, many years ago when Endocut was just, a pure Endocut cutting current. But now most of the electrosurgical units are actually blended current. Even if you use the yellow, let's just talk, layman language, just yellow, right? I actually just use yellow. Most of the time when I'm dealing with a sessile lesion, but there are some tricks that hopefully we'll work with and learn during the hands-on session that we usually close the snare all the way to the hub to minimize the amount of tissue that's entrapped into the snare. So and with that we use yellow. We minimize the as Dr. Othman said, the electrosurgical current that's going through the tissue. That's on the expense, as shown by the study Muhammad alluded to, is that sometimes you can see a little bit more oozing, a little bit more bleeding after just using the blended or the yellow pedal, but that's usually you can take care of right at the same time. So I personally just use the yellow pedal or the blended current. Do you have any?
Yeah, I like endocut for a lot of those same reasons. I think you get better progression of the snare through these larger lesions. But you do have to be careful because you could easily go transmural with the endocut setting more so than force coag. If you're using force coag, you maybe get a little bit more of a clue that you have a little bit too much tissue. And I think that's one of the proponents for that, like that setting a bit better. But interested to hear what other people on the panel have to say.
All right, so we'll change topics now. The next question is for the panel and for Dr. Han. Fantastic lecture on ergonomics. What is exactly entailed for a micro break during a procedure? For example, are you just stopping everything? Do you have someone hold the scope while you take the micro break? Can you explain?
Yeah, I mean, the essence of it is just taking time off, 1 to 2 minutes. If you have a fellow, you can have them hold the scope. You can also ask you can also have a nurse hold the scope for you as well. But it's just basically stepping away and letting yourself kind of recharge.
Right. So I think that, we talked about mini breaks and micro breaks. So mini breaks are between cases, and Sam was saying I disappear between cases sometimes, but I actually don't disappear. I'm catching up on a bunch of stuff, but I'm not there doing the same awkward movement that I was doing for 2 hours before that. So that's the mini break. And the micro break is if you're doing a long case, and by long, I mean like, 2-3 hours or so, ESD or complex EMRs, or even, some tough ERCPs can be awkward. The point there is at some point, you should not continue in that posture and just take a break, which may be just resting the scope, as long as it's appropriate clinically in that procedure to stop it. And even if you just take a little walk in the room itself, that's good enough. My nurses joke that, they call it the 7th inning stretch, that I'll often will say, okay, here, I'll just put it down and stretch and kind of get back and regroup and refresh. So it's nothing special. It's just a little break.
Don't be looking at your phone when you're taking your micro break, right?
No, yes,
Yeah.
no phones during micro break. Mini breaks would be okay between cases.
I have to say you have to find a better name if you practice outside the U.S. I was working in Jordan the last few months and doing a poem, and I said, "Let's take a seventh inning stretch," and it was like, "What is seventh inning stretch?" It was like, "Well, we need to talk about baseball first." That was a long.
Whatever the equivalent is for soccer, right? Yeah, you got to find. Yeah.
All right, so we do have a bunch of questions. So, which one was, I think it was this.
Yeah. Sachin, this is for you. What is your preferred modality of ablation of Barrett's, RFA versus cryo? Are there certain scenarios where you would choose one over the other?
Okay, so I know you have a lot of questions, so I'll just be short and brief. So the preferred ablative technology is radiofrequency ablation. That's where we have level 1 evidence. I do use cryotherapy in patients that have deeper invasion, and I'm performing palliative therapy. In rare instances where the patients have not responded to radiofrequency ablation, I would consider cryo. But before I pull the trigger on using cryo, I want to ensure that the acid reflux is addressed. If the patient has persistent erosive esophagitis, consider performing a fundoplication before you pull the trigger for performing cryo or hybrid APC.
Perfect. I'm just going to do one follow-up Barrett's question, and then we'll move on. There's that one that I just saw about circumferential. Oh, here. No? For large segment RFA of circumferential Barrett's, do you recommend stage sessions of RFA to reduce complications like stricture formation?
For long segment, for circumferential ablation,
Yeah.
no, I tend to treat the entire Barrett's during that session.
All right, Dr. Barron, what is your opinion about supine versus prone ERCPs? Does one versus the other affect cannulation rate in difficult cases?
So I haven't performed a prone ERCP in probably 12 to 15 years. Every case I do, in fact, even therapeutic US, I do them all supine. But, you know, so I don't recall having to roll somebody prone, although recently one of my colleagues said that they could not cannulate and then rolled patient prone and actually got in. So, but I'm not aware of data. I can tell you that it's very different cannulating supine versus prone. But I've been doing this so long, I don't really know if it, what it would be like to go back the other way. And I don't know of any data comparing success rates of one versus like randomized trials.
But I do have a follow-up on that. So I found that the main difference between prone and supine is the position of the monitor.
Oh yeah, for sure.
So I'm assuming in your unit, since you're doing them all supine, your monitors are situated where your back is to the patient. So
well, right, correct. So you can't look across the bed unless you're an owl when they're doing supine. And your body is rotated way to the right. And so we have the monitors like I'm looking at the head of the patient. And really, I started doing it when anesthesia first, you know, you guys forget we had to do all of our own sedation for years and years and years. And then when anesthesia started, I would watch 15 to 20 minutes of getting them in position. And I'd say for prone, and I'd say I could be done with the procedure by now. Just put them on their back and I can do it. So the anesthesiologists love it, you know, because they can just put them to sleep on their back. They don't have to transfer. They don't have to do chest rolls, that sort of thing. But the fellows, when they come in, if they've been at other programs and places, they're finding it difficult.
Perfect. Okay, there are a couple more questions, but all of the faculty are going to be there for hands-on stations. So as you see them, you can ask them any directed questions just for a matter, for sake of time. It is 12:04. We'll try and start this session again at 12:10 and go to about 12:40. So grab lunch and we'll meet you guys back here.